Yeah, my name's Mark Newbold. I graduated from here 30 years ago, actually. We had our 30-year reunion about 3 weeks ago in this building, which makes me feel quite old, actually. So I remember this lecture theatre. This is the title I was given, and what I thought we'd do is maybe just talk for 25, 30 minutes and then have a discussion. So happy to answer any questions you would like. You know, why should doctors get involved in management? You're obviously interested. That's quite new, and actually I'm seeing quite a lot of younger doctors showing an interest in leadership and management, which never happened up until about 18 months, 2 years ago, I would say. So something's changing, which is good for reasons that we might get into. So I'm relatively unusual in being a medic who's a chief exec. There are probably half a dozen at most at the moment. It's a number that fluctuates because we don't have a long life expectancy in post. But and Tim, who you saw last week, is equally unusual because he came from outside the NHS, and that's actually quite unusual too. So I thought we'd answer the question, why should you get involved in management or in leadership, and then just finish with a couple of slides which I show to new consultants who are getting involved, and then we'll have a discussion. So hope you find it of interest. So I think it's pretty obvious that in healthcare delivery doctors should get involved, but you know, it isn't tokenism, because actually you have some understanding and some skills that nobody who's not a medic could have. And I think some of these are valuable reasons why you should get involved. And I won't go through them individually because we'll keep coming back to them in different forms. But you know, you do spend most of the money. And you do have, I think independence of mind is really important, and I'll get to that right at the end, because you know, management shouldn't be about following protocols or doing what the politicians say. There's something about doing what's right, and doctors are quite good at that once they can latch on to what's right. But the real point of today is to say that actually most of the real challenges that managers face are inherently clinical or healthcare related challenges. They're not dreamt up by politicians or by the Department of Health. Those are just the rules and the frustrations often. The real underlying challenges, I think, are ones that doctors can address better than anyone. And the NHS is in a difficult place at the moment. It's more unsettled and more feels more shambolic, really, than I can ever remember. So after the reforms, the organisation is not clear. After 10 years of reducing waiting times really successfully, suddenly we had Mid-Staff St Francis and quality came on the agenda, and all of a sudden, almost overnight, it felt like we weren't delivering what the public's priority was. So we were congratulating ourselves that you could get a hip replacement in 18 weeks when it used to be years, 10 years ago. But suddenly all the noise and all the talk was about compassion on the wards and complications of treatment and outcomes, and suddenly things seem to have changed. And after the Francis report in February, the big thing that's come under fire is the culture of the NHS. So why doesn't the NHS listen to what people are saying and what patients are saying and what staff are saying? So there's a whole industry. Those of you who are on social media will know that there's a whole industry around whistleblowing and why the NHS doesn't seem to listen to people who raise genuinely held concerns. So the whole way the NHS operates is under fire at the moment. And so I think you will work in an NHS that operates in a totally different way than the one we're used to, which some people call the targets and terror regime, a very strong top-down drive. You will do this, you will do this, you will do that. This is a standard you must achieve, and there's no argument about it. And yes, of course you can innovate and do what you feel's right locally, but you've got to do all these things first. And I think that is going to change in the next 2-3 years. The money, I mean, in the past we've probably shied away from some of the changes and just bought our way out of it. So when Gordon Brown was Prime Minister, he put an unprecedented amount of money into the NHS. That no longer is available. So whatever we do, we're going to have to do it within the existing resource. Media I've kind of covered. I mean, the media always prefer a bad news story, but it seems unrelenting at the moment. And our trust is about to prompt another big round of bad news in a few weeks' time, I suspect. But actually the other argument I'd make is actually I don't think we're catering appropriately for need anymore. So 60 odd years ago when the NHS started, it was based on an acute model of care. You were well, you got ill, you were admitted, cured or got better and went home. Now most people we admit have got chronic conditions. Most people who come in acutely have got a flare-up of a chronic illness from which they will never be cured. Chronic heart failure, chronic obstructive airways disease, those sorts of things. And if we manage them better, actually they probably would have fewer flare-ups and fewer admissions. The NHS isn't geared up to do that at all. It's very reactive. You have to seek help. And many people don't seek help until they're quite ill. And so we have high readmissions and so on. So I think there's a bigger question, which is actually it's no longer really properly fit for purpose. And I just quickly point out some underlying issues that we never talk about because we only ever talk about what the politicians are saying or what the latest target is or what the latest scandal is. But there are some underlying health issues that we don't address. So this is Birmingham and Solihull. Our trust covers the kind of right-hand side of that, about 1 million population. The dark areas have a life expectancy 10 years less than the light areas. So if you go from north, which is Four Oaks, Sutton Coldfield, through Erdington and the centre of Birmingham, where Heartlands Hospital is, and down to South Solihull, you'll see a 10-year gradient in life expectancy. How often is that talked about? There are some serious health inequalities right on our doorstep. And I would argue that that is a challenge for those of us who are running health services. It isn't all about budgets. This is the Commonwealth Fund, which is kind of a think tank, a King's Fund type organisation in New York. It's a couple of years old, but you can see, if you look at, this is health economies across the world. The UK's outcome, this is mortality from conditions amenable to treatment. The UK outcomes are not that good. They're not terrible, but they're nothing to be particularly proud of. Lots of European countries manage far better outcomes than we do. So again, beneath the rhetoric and beneath the headlines, there are some serious issues that we don't talk about enough. Then there's Francis. So self-evidently, those are things that doctors could address pretty well if they were involved in leadership. I've mentioned Francis already. That's Robert Francis, whose second report came out in February. Suddenly put quality at the top of the agenda, which is where it should be. And it's people like me say that all the time, but actually the official targets by which I'm judged have always been around budgets and access targets. They are, at the moment, as we speak, quality is not officially and formally at the top of the agenda, but I think it needs to be. And I've already mentioned the cultural issue. We don't have a particularly effective relationship with the general public either, do we, in the health service? We're not very good at engaging and having a dialogue with the public. They don't trust us. We only go and speak to them when we want them to agree with a change that we want to make. And so every time we try and make a change, even if it's for the better, you get a response. So, you know, Lewisham Hospital, that was earlier this year. Even Stafford Hospital, interestingly, which is now going to be downgraded, I'm sure. Tens of thousands of people take to the streets every time there's a change to local services. They don't trust us, and we don't articulate well why we need to change things. So in London, they've gone from 24 hyperacute stroke units to 8, with a measurable improvement in mortality and reduction in morbidity. But that kind of, everyone quotes that because it's one of the few examples where it's actually happened and the public haven't argued against it. So we need to do something about talking to the public, and doctors are arguably better at that than bureaucrats. I've already mentioned the money. We don't go, even NHS managers, their prime aim is not to balance the books. That's just a constraint. The prime aim is to deliver healthcare to rising standards, but you have to live within the budgetary constraints. So it's wrong to say that managers should be primarily focused on money. If you primarily focus on money, you will get all the priorities wrong. But of course, you have to live within your means, as does the country. Those bars are the annual increase in NHS funding each year, going back about 30 years. And over right on the right-hand side, you can see that it's essentially flat cash now, which sounds okay, except there's about a 5% rise in demand every year in the health service. So when you hear about the 5% efficiency target, it's because we've got the same amount of money, but 5% more work, broadly speaking. But it's not why we come to work, it's just a constraint. And then you get to the really interesting issue for doctors, I think, is about how much of a responsibility do doctors have for operational delivery of day-to-day performance in hospitals. So this was last winter when everyone suddenly realised that the NHS couldn't cope with emergency pressures anymore. So our trust, that's my trust's 4-hour target performance, which we really struggle with it. We sort of got it right for 5 quarters, those 5 green bars, and then it went bad. And you can see that really low figure, which was in the end of last winter. But by the end of the winter, it was quite clear that the whole NHS, by and large, could not cope with the emergency pressures. And you would still hear doctors saying, well, the 4-hour target's nothing to do with me, that's a political target. But actually, it's a good measure of flow and pressure in the system. And if you look at our mortality, that's our running standardised mortality rate for the trust. You can see right over at the right-hand side a significant spike which went outside the control limits at the end of last winter, which coincides with the really poor performance on the 4-hour target. So actually, poor performance is clinically important, which brings you round to the view that actually it is part of doctors' professional responsibility to ensure that services run smoothly. And I don't think the profession as a whole understands or accepts that yet, but it's becoming much talked about. The day-to-day performance absolutely is your responsibility. It's not just the single patient in front of you. The way the services work is a clinical issue, a professional practice issue. And when you start unpicking why we can't cope with winter, or actually summer either, emergency pressures, this is when you get to this business about the nature of the demographic change. It isn't just ageing population, it's the fact that an increasing proportion of the population have chronic, lifelong chronic conditions, if you include frailty as a lifelong condition. And when you look at our emergency admissions, which is 70% of the work in our trust, the majority are coming in with a flare-up of a long-term condition. And if you look at people who are readmitted within 30 days, which shamefully is somewhere around 12% of our emergency admissions have been in hospital within the last month, then most of those will have a chronic condition or more. You can have these slides, by the way, so please don't feel... So I think we're actually running a model of care that isn't catering for the most needy people at the moment. So if you're frail and elderly with 1 or 2 long-term conditions, really the service does not provide what you need. It's too reactive, it's too hospital-centred. And you know, it's self-evidently a clinical issue, I think, to start to resolve that. And just to labour the point, these are our readmissions in our organisation, and if you separate out those who are readmissions within a month, you can see they have a significantly higher mortality rate than the norm. So they're a vulnerable group. So again, this isn't just an inconvenience that they're back in hospital. It is associated with a measurably worse outcome, and I don't think even a majority of doctors would know that yet. And then you look at even busyness. So we have these things called escalation levels, 1 to 4. 4 is crisis, and it effectively means the hospital should close, except that you can't close in Birmingham because there's nowhere else for the ambulances to go. So that's level 4. Level 3 is effectively running red hot, and we would be on level 3 in Heartlands and Good Hope Hospital, certainly on tens of days a year, probably hundreds actually. And you can see that the mortality rate for people admitted on days when we're on the level 3 is significantly higher than when we're running normally at level 1. Except, sadly, level 1 is probably less common than level 2 at the moment because we run very hot most of the time. So again, you know, arguably we should have red flashing lights in the corridors when we're on high levels of escalation, but it's become the norm. You know, through a difficult winter, we will nearly always be on level 2 or 3. But the outcomes are worse. But if you were to pick doctors at random, they would tell you it's unsatisfactory, they would tell you it's demoralising, but they wouldn't immediately tell you it's dangerous for patients, but it is. So it's a clinical issue. And then after years of talking about bed blocking, I think we're finally, the penny's beginning to drop. So this news story was from this month. And it's the first time, and Adam Brimelow is quite a thoughtful journalist with quite a good understanding. And for the first time, there was a news article saying the elderly who are in hospital for a long time, they're not just blocking beds, they are actually being actively damaged by long stays in hospital. So we know that if you're 80 plus, after day 6, your mortality starts to rise quite steeply, and your chances of getting out of hospital reduce by the day. The worst things that can happen are you might not get out, you might acquire hospital-acquired pneumonias, C. diff, those sorts of things. The least that will happen is that on a daily basis you will become less able to fend for yourself and get back to where you came from. So we are institutionalising people. We've just opened a convalescent unit on the Good Hope site with single rooms, something that looks like a home. And we moved a lady over on Monday who the ward staff said can't walk. And within 24 hours she was walking and making her own meals. And so if you put someone on a ward, they will appear and become much less able than they really are. So I think this narrative is going to start to gain ground now, really. You know, we are actively harming people, which brings you round to saying if you're a physician who's not managing timely discharges of your patients, then you are actively harming them. Therefore, it's a clinical practice issue. Similarly, if you admit them inappropriately, thinking the ward is a place of safety, it actually isn't a place of safety for a frail elderly person unless they are ill enough to need it. And if you look at medical intervention in hospital, after day 3, it's a tiny proportion of the patients who actually need medical intervention. They're normally on maintenance therapy and needing nursing and therapy support. So really our hospitals should be really focused around a 3-day length of stay, and ambulatory treatments with only a very small number of specialty beds that keep people in for longer than that. So when you reframe the problem from bed blocking and poor management to actually poor clinical practice, it takes on a completely different look. And that's the debate we're having with our docs at the moment, who don't get this, by the way. This is quite new thinking. So I think we're facing a number of challenges, whether you're a CEO or a medical director or whatever. And my argument is they are essentially healthcare-related challenges. So doctors are better placed than anyone else to think through what are really complex issues. They're not simple, but to think them through and to work out how best we cater for people with this changing but growing need. So that's the Royal College of Physicians report from last October, which pointed out that actually hospitals aren't the problem, hospitals have a problem, because the way the whole system is working is leading them to be offering substandard care for the majority of people who are in. So carrying on the theme, so we need to do something different about chronic disease management, and that debate is very much around the role of doctors. So the Royal College of Physicians really got its act together at the moment, actually. So this Future Hospital Commission report, which they have led, came out a few weeks ago. And it talks about a changing role for physician specialists. It basically says, we understand why you all want to be ologists, but actually you need to get back to the front line and supporting the acute general take in your hospital, which is not a welcome message for a lot of them, who normally, success is getting off the general take rota, basically. And then they go further and they say, actually, you may be employed by hospitals, but you could have a really effective role working out of hospital, helping to keep people well who have got long-term conditions. And that really is a change in the way they work. So we'll have to see how this report goes. Of course, some GPs will say, well, our job's chronic disease management too. So there's some negotiating and some discussion to go on, but we're getting to the point when the way the NHS works is getting right to the nub of what doctors spend their time doing, whether they're generalists or specialists. So again, clinical issue. Can't do that without the involvement of doctors. So I think what I would argue is that what we need to deliver is all about what doctors do. So why wouldn't you have doctors involved in management and leadership to help with that? And I'll just reiterate, we don't come to work to deliver financial balance. That's just a constraint that we work within. It is not a prime driver. And even when you look forward, what do we need to deliver tomorrow? There are some really significant changes, as I've already alluded to the way doctors work, which we can't do without doctors being involved. So 7-day working on its own is a massive issue. That's actually being led by Bruce Keogh, who's the NHS medical director. That is being medically led at the highest level. But all of these changes that need to happen are really around doctors and the way they work. So any way you look at it, I think, you can't say that management and medicine are completely separate. So just before we have a discussion, I sort of just put a few slides up which I put up to new consultants and who are on management courses. So this is what I think we look for our clinical leaders. When I asked a group about 2 months ago, what development do you think you need? What would you most want? The commonest response that came back was, we'd like to learn how to read a spreadsheet. And I said, no, why do you want to do that? I never read a spreadsheet. Why would you want to? These are what's important. Making sure that the organisational priorities are right, making sure that you look forward in your specialty and advise the services as to how they need to plan for the future. Getting colleagues to agree, which is probably the hardest thing of all, actually, because you guys are all trained to be independent thinkers and take responsibility for your own actions. That's really hard then to get consensus. It doesn't necessarily come naturally. And GPs, it's even more difficult than it is with hospital doctors. But clinical census is essential. If you go into any hospital in the city and look at the successful services, you will find a group of consultants who agree on the future and who are working together to achieve that. If you go and look at poor services, you will find a dysfunctional rabble. Nearly always there's a direct correlation. So just a few things. I really like this definition of management and leadership. You must have seen it. It's Drucker. It's from a long time ago. But I think that sort of sums up, if you like, the difference. You can't have one without the other. Leadership without management means you'll have ideas but no implementation. And if you have management without leadership, you risk just doing the wrong thing. So I think it's really quite a good definition, I think. And one of the things I say to doctors as well is that most influence and power in an organisation does not come from titles or formal roles. It comes from the sorts of things that many doctors will inherently have, which is why it's so difficult to make change without the doctors involved. When I had my first clinical director job in pathology, a supposedly wise colleague said to me, whatever you do, don't accept the job unless you have budgetary responsibility, because without it, you've got no power. And a year later, somebody who was wiser, in hindsight, said, why on earth did you have the budgetary responsibility? It's only powerful if it's an sufficient budget. If it's an insufficient budget, it's a millstone round your neck. And he was right. He was more right. So power comes from other things that are softer things, that are less formal and not conferred. And I think it's really important to say that a lot of doctors think that there's something really devious and Machiavellian about management, and that you can only do it once you get invited into the inner sanctum and given the black book. It really isn't a dark art. It is really just about doing the right thing and getting people, engaging with people and getting consensus and moving in the right direction for the patient. And we mustn't allow this sort of myth that it's somehow a dark art to be maintained, because it's really not about that. It's quite straightforward, actually. It's about people, and it's about looking at the priorities and looking at the challenges, working through how to address them in the interests of the patient, and then moving forward. It's as simple as that, although it's not actually easy, but it is, in theory, simple. And this slide's quite an interesting one. The Leadership Academy showed this at a conference last week, but they looked at organisations which had differing levels of engagement and other leadership aspects along the bottom and compared them to the mortality rates. And actually the organisations that score best on those scores of leadership do have the best outcomes. So it really matters that it's not about the managers or the leaders as such, but it really matters how engaged and how bought in and how together the workforce is. It actually matters to patients. And the other thing we do in the NHS a lot is look up. We wait to be told what to do. And again, doctors are less inclined to do that. But, you know, what Jeremy Hunt and others want to happen is very broad. It's how we implement it locally that actually matters, although he's doing his best to interfere quite closely at the moment. So I just thought I'd finish, and we'll have a discussion on any aspect of this, but you know, the stuff about doctors and teamwork and working to make sure services are delivered right is not new, actually. So Liam Donaldson, who was the Chief Medical Officer for years, many years, said this in about 5, 6, 7 years ago. You can read it for yourself, but what he's saying is that, you know, the outcomes for patients depend on much more than the individual doctor-patient interaction. The way in which the service is delivered and the way in which the different professionals work together have at least as much impact on outcomes for patients, and therefore it's a clinical practice issue, and therefore it's something that the profession needs to get involved with. Thanks very much.